Welcome, everyone, to another episode of Closer to Wellness. I have with me today my favorite, Dr. Kandace Kichler. We are going to have an amazing talk. I just want to say a little bit about her. Dr. Kandace is a board-certified surgeon at Haas Plastic Surgery in Palm Beach Gardens and Wellington, Florida. She's a native of Alabama. Dr. Kandace pursued her undergraduate degree at Auburn University. She then completed medical school at the University of South Alabama College of Medicine. She did her surgical training at the University of Miami, which I think is kind of a circle that we kind of ran in together.
Yes, girl.
Dr. Kandace, let's see, and that's what brought her to South Florida, where she stayed to complete her minimally invasive fellowship at, the Cleveland Clinic?
Yep.
Yes. Let's see. After several years in weight loss surgery, Dr. Kandace went on to pursue plastics, which was encouraged by Haas Plastic Surgery.
Yeah.
Yes. And so that's where she is now. She's a fellow of the cosmetic, the surgery?
American Academy of Cosmetic Surgery.
Yes, forgive me.
And the American College of Surgeons. So I'm FACS, FAACS. Yep.
Yes, she is all of the things that you need in a plastic surgeon for sure. And no more bariatric surgery?
No more bariatric surgery.
Okay. Dr. Kandace works with Haas Plastic Surgery now, performing all of the top-notch plastic surgeries in addition to injectables and obviously consulting on other procedures as well. Welcome, Dr. Kandace.
Thank you for having me, Bonnie.
Yes. So you and I spoke recently about this podcast being about wellness and how I would love to incorporate some of your procedures and your current activities along with my pursuit of wellness for my patients. So I have a lot to do with mental wellness in addition to physical wellness. And as we all know, as women, it tolls on us a lot when we feel like we don't like what we see. So there's a big world of plastic surgery, facials, mommy makeovers, facial surgery, mommy makeovers, tummy tucks, the butt lifts, all of the things. So I wanted to get into it a little bit about where our mental health, our mental wellness, and our physical wellness go along with plastic surgery. And then I wanted you to kind of, if you can, maybe say, what are the most common things that our women are coming to you for? Let's just do a healthy wellness type surgery talk.
So I think you and you already stated it, but you and I both know if you don't feel good and you don't look good, they kind of go hand in hand. So when you feel bad, you feel like you look bad. When you look bad, you feel bad, and it is just this constant circle. So if there's something that significantly bothers you and it becomes a day-to-day thought or a day-to-day, annoyance, then it starts to wear on you mentally, whether that's just something you think about, you push to the back of your mind, or something that you fixate on, or something that affects not only your self-esteem, but your relationships with others. So your physical appearance, whether we like it or not, because we are in the age of body positivity, it does impact your function mentally, physically, emotionally, all of the things. So if there's something that is bothering you and you want to do something about it, you have the means to do something about it, it is reasonable. I'm not suggesting people should go, get these dramatic transformations, but if it's something small and something that can be, maybe tweaked, then by all means, it does tend to improve self-esteem in the long run.
So I want to say something on that one. When we say it involves others, our other relationships, I do have some women that I counsel that when they walk around and they are putting out that energy that they're just unhappy or don't like something, or it's a feature that's bothersome to them, and they keep picking at themselves, I try to make them aware that your children are noticing this and you're putting that insecurity in your children. And God forbid if they have the same feature. Like I had a patient she wanted to non-invasive rhinoplasty. So I did her, her filler. And then she came back about 9 months later and she said, oh, I shouldn't have done that because my granddaughter has the same nose, and I made her feel a type of way about her nose. So, to all the listeners, plastic surgery is something that I think is a great option. It's a safe option as long as you don't have the comorbidities that kind of exclude you from it. But it is something that those features, when you pick on yourself so much, you are affecting your children and the people that are around you. So I'm thankful for plastic surgeons and their safety profile and everything that they are able to do for us.
Yeah, absolutely. And it's not just your kids, it's your spouse, it's your potential spouse, it's your coworkers. It really impacts every interaction you have with another human when there's something that bothers you. Like, I am a victim of that type of situation. Like, let's just call it what it is. I was a flat-chested, skinny little girl, and it was so hard for me to want to date, to be intimate with people, to feel confident in clothing when I was going to job interviews, even just interacting with people in the hospital when I was in training before I had my breast implants was it seems so silly looking back, but it was something I thought about every single day, every day and every night. And, to not have that constant thought in your head is really, it's like a huge relief. So if someone has something like that, then I encourage them to explore that, to see okay, if you do this, do you think it's going to make a difference? And how is it going to make a difference? And, is it something that's reasonable?
Right.
And if it is, then just do it.
There is a positive correlation between success and kind of either accepting the way that you look via therapy or, whatever.
Yeah.
Or if you can change it, then change it. There is a positive correlation in the level of success of people. I mean,
Right.
there is.
Right. Definitely. And I would say, the kind of example that you gave with someone who didn't want to change something that was maybe a trait, like a family trait or something that, they identified with their relatives. That could go either way. I see her side of you where she regretted making that adjustment, but at the same time, you could go out a different way. You could say, you know what, sweetie, I was really bothered by this. You look absolutely beautiful. And if this is not something that you ever think about or that bothers you, then there's no need for you to change it. However, for me personally, it was something I thought about, and just having those real conversations, I think, are important.
Yeah, no, it's so important. So along the lines of maybe the external things that we all see that maybe a woman is bothered by, there's also the things that not everyone sees. And I think we touched on the part of it affects your spouse. So there's certain things, for instance, like the mommy makeover, but in addition, and I don't know if this is included in a mommy makeover, maybe it is, labiaplasty. Do you do that as well?
I do. Okay. I do the external labiaplasty. So I do work on the labia majora and the labia minora, and I don't do internal tightening like vaginal rejuvenation, that type of stuff. But yes, huge deal. And I will say I get some inquiries. Oh, my husband wants this. My husband wants that. We are not doing it for them.
Right.
We are doing it for us.
Right.
And if there's something anatomically that you don't like about your woman region, there are things that can be done. And it's really, everyone feels isolated, when they have a problem there or they sense they have a problem there. It's so hard because you don't want to tell your girlfriends about it because they're going to think you're weird.
I love this talk.
You don't want to tell your daughters about it because you don't want to inflict some type of thing on them. You can't really talk to your mom because it's you don't talk to your mom about your coochie. There's a whole situation around it. And to find someone who you can just say, hey, I just don't think this looks right. I'm bothered by it. Can you take a look? That is what I'm there for.
Yes.
Normal, not normal. If it bothers you, let's do something about it. There are a lot of people who are born with asymmetries and, they can get worse or better with time, with aging, with hormones, with childbirth and things like that. And if it becomes something that, again, bothers you regularly, it's not a majorly invasive procedure.
Okay.
So it's something that you can go through. I even do them under local.
Okay.
So, no anesthesia, very minimal downtime, that type of thing. And it makes a huge difference. I haven't had a single person say, oh my God, I wish I wouldn't have done that.
Yeah.
With regards to a labiaplasty.
And since it's external, really, there's a minimal risk of messing with the innervation and just kind of.
Correct. And I specifically as a practitioner, I stay away from the clitoral hood. There are some doctors who have, maybe different background than I do, who are comfortable going in that region. I just stay away from it because I'm like, we're not trying to mess with that. We are only here for the cosmetic aspect, and that's what we can fix.
Right.
Yeah.
So hear that, listeners, if you ever thought of having your nether regions a little double look-see, it seems like this is a common occurrence. Don't be afraid to discuss it with a plastic surgeon or even myself. I constantly talk about the vagina. This is so fun. I call it the vagina dialogue. Everyone, and as you said, people think that they're isolated and it's only them. So I talk about vaginas most of the day.
Yeah.
Most of the day.
Well, and there are a lot of things that you can do non-invasively too. Yeah. Like you can put some Sculptra, you can put some Renuva. There's a bunch of different fillers, and things that you can do for the majora maybe, which is the part that typically contains the hair that we all shave off now, depending on what area, what age we're in. We laser it. But yeah, there are a lot of things that can be done depending on what bothers you.
Does Haas or would a normal plastic surgery center in general, is there a machine or device that's maybe non-surgical that
so for the internal, the internal symptomatology. So maybe you feel dry, maybe you feel not tight anymore, maybe you feel just different than before, or you have issues with urinary incontinence or urgency or hesitancy, all these things, like a gynecologic, urologic issue. There are it basically looks like a wand, kind of like the ultrasound you get when you're about to have a baby.
Right. Is there one that you believe in?
I don't think any of them are dramatically better than the other. There's like the Mona Lisa, the Thermiva. There's a couple other ones on the market. I've only had experience with the Thermiva. I've had other people have great experience with the Mona Lisa, but it's typically a radio frequency. Okay. So it's going to go in and kind of, for lack of a better word, zap things, wake them back up, tighten the muscles. Yeah. And that cascade can induce changes in the mucosa so that you have better lubrication. It can affect the surrounding tissues around your urethra. So the urgency or the issues with frequency, like peeing on yourself when you jump, for people listening, could potentially get better just from a couple treatments, which are like zero downtime.
Perfect.
Okay. Yeah. So there are lots of options. Yeah.
Okay, listeners. So vaginal dryness, urinary incontinence, feeling a little bit laxity. Yeah. Non-surgical, few visits.
Yeah. And I know there are some, it's more likely a urogynecologist or gynecologist who can do actual surgical internal tightening, but it's just not something that I do.
Right.
Yeah.
Yeah. Well, it's good to know that it's something that's offered that's non-invasive in the event they can't have that downtime or kind of go through surgery.
Exactly.
Okay. Well, so that brings me to, so we've discussed a little bit of the external and the more private types of surgeries. Let's talk about breast implants for a minute. Can you tell us, because again, this is like what you said, like if you're flat chested and you just feel like lack of confidence and you know that you could look different and you would have a little boost of confidence or it would get you further in the world. I mean, it's each our own decision. I have implants as well. Same story.
Yeah.
So when I had mine, I have saline. So, and I was given the option between the two, but it was so long ago, I don't think I really understood which one should I get. And then there was the option of above the muscle or under the muscle. So let's talk a little bit about types and where.
Location. Yeah, exactly. So like you alluded to, it's typically silicone or saline. Okay. Saline is basically a water balloon, for lack of a better word, in a silicone shell. So it does still have a silicone component, but it's filled with water. And these have the potential of just like bursting and deflating. But I have saline also. So we've lived our days and we're just fine. Silicone today is different than silicone before. So silicone before was like the typical jelly silicone that you think of that, can ooze out and get into other substances or structures. Today, the silicone implants that we have are silicone gel. So they are more cohesive. So the silicone has been cross-linked so that if you literally cut into that implant, nothing leaks out. it stays in its shape. It's also called a gummy bear. So if you think about when you bite into a gummy bear, the insides of the gummy bear aren't falling over the floor. They're staying in that shape. So that's what we're typically working with today. And there's been, different coatings of these implants in the past, soft, like smooth or textured, because there was a time when we thought textured was going to hold its place better or form a better capsule. That has been disproven. And so in the United States, we typically only use smooth implants that are either silicone or saline. And each has their own benefits as far as appearance, look, cost. There's a lot of stuff that goes into what you should.
So there's a price difference between
typically saline is cheaper, which is why I got mine. I was poor. I was in medical school. I was like, let me get out a loan for this and finance my breast. So I did. But I actually like mine. I don't have any issues with mine as of today. I want them larger, but that's not a functional issue. So silicone, saline. And then when we talk about placement, under the muscle or over the muscle. And the muscle we're referring to is our pectoralis muscle. So you've got pectoralis major, pectoralis minor, but an implant can go underneath that major muscle. And if it's placed underneath, then it gives a more natural appearance. So it's not just a implant or a device, a prosthesis sitting right under your skin. It kind of fits into your chest wall. Like it looks like it's part of you. They came from you. They look like they are your breast. So most surgeons will do under the muscle these days just because of the aesthetic outcome that you get. In rare cases, maybe you've had something under the muscle and there was an issue. Maybe you are a bodybuilder and you are severely, concerned about your pec functionality. Then above the muscle is still an option. And we see people all the time who got above the muscle years and years and years ago. And they tend to have a slightly higher complication risk down the road. And that's typically with what we call a capsular contracture, where the body sees it really as a foreign body. It doesn't like it, walls it off, and it feels more hard than the implants that we place under the muscle. And you can choose where your incisions are too, typically, but most people today are putting them in the inframammary fold. So where your breast folds naturally, that place where the underwire sits on your bra, that's where most of the implants are placed through an incision there, versus there was a trend of the armpit, but there was a little issue with how the pocket was dissected, so they didn't look as great. Some people would go around the nipple. That looks great the first time, but if you ever try to do it again, then you'll get a dent in your nipple. And then through the belly button, that's popular in countries where, it's very taboo to get implants. So you really, really hide the scar completely, but it's a long way from your belly button to your chest wall. So, simplest, safest, most direct approach is through the inframammary fold. And that's what I do.
Yeah. I think I've seen it as most common. So there's a price difference between the saline and the silicone. Typically the saline's a little bit cheaper, and it sounds like it's individualized as far as who's getting under the pec and who's getting over the pec. It doesn't.
Most people are getting under the pec.
Yeah.
Or some hybrid version. So we lift up the pec, but then we do a little tissue dissection lower. So you'll see if you look online, we love to trend things. We love to sensationalize things. So you will see surgeons saying, oh my gosh, I do this dual plane technique. Okay. It's still under the muscle.
Yeah.
It's the same shit, different name. Okay.
Right.
Yeah. So
any version of under the muscle or even partial under the muscle, it does assist.
Tends to look better.
It looks better and decreases the occurrence of contracture.
Capsular contracture. Yes, exactly.
It sounds like a plan.
Yeah.
So on the grand scheme of things, when we're getting our implants, we're getting them usually because either this is a cosmetic thing that we've wanted, or it's because maybe we had cancer, we had a double mastectomy, single mastectomy, whatever, and you're doing a reconstruction. So in those instances, those are options at the end of the day where we want to get that surgical procedure, and we're getting either saline or silicone. So let's talk about any risk after the procedure, and then maybe things down the road. Like, what are you seeing people maybe complain of? Yeah.
So surgery is surgery. Okay. At the end of the day, there's always something that can happen. It's typically rare, but anytime you have a procedure, we're cutting. Okay. We're cutting through blood vessels. We're cutting through muscle. So you can have bleeding, you can have infection, you can have bruising, you can have scarring, all of these things are going to happen to some degree. It's to how much they happen. Yes. Nerve damage. So change in sensation to your nipples. For women who potentially want to have children down the road, there's this question of what degree it could affect your lactation, afterwards, if you get the implants or you maybe get a lift before you've started nursing or had babies. The capsular contracture, which I spoke about, is essentially everyone makes a scar tissue capsule. So anything that you do, any cut that you put on the body, your body is going to lay down scar tissue. And that is its healing mechanism. So it's going to lay down new collagen, new elastin, all of the things. And how thick or soft or hard or irritating that capsule can be depends on you and your body. And there are some factors, of course, in surgery. If you've got a rough surgeon and it's bloody and, they're not taking their time, then yes, of course, you can maybe have a higher risk with something like that. But at the end of the day, it's still your body's response to that trauma, and surgery is trauma. So capsular contracture can happen. It's rare. There are certain things that we can do to kind of mitigate that. And then otherwise, the implants can rupture. They could get malpositioned, especially if you're not, following your surgical protocol postoperatively. And then, the elephant in the room that we'll eventually talk about is the BII or certain cancers or things that may be associated with the implants.
Right.
Yeah.
What about the syncytia? Is that what it is? The syncytia?
So basically, synmastia. So where uniboob. Nobody wants uniboob these days. That's typically from over dissection. So if the surgeon goes too, it's a technique thing. So too far medial with the dissection, goes through the pec medially and then into some of the soft tissues and whoop, I'm on the other side. That rarely happens.
Gotcha.
Yeah.
Is there, and I don't,
rarely.
Right. I've only seen it on botched.
Yeah.
Probably the same woman each 3 times. It was probably a man.
Well, and people that, have unreasonable expectations.
Yes.
If you want 900 cc implants and you're typically a size 0, 5'1" woman, it's not going to work.
You're going to fall over.
Yeah. Yeah.
So, and then so I wanted to ask you about the occurrence of the synmastia as well.
Yeah.
So I don't know that this is an actual database or a figure that people can find, but when you are looking for a surgeon, is there a way to tell how many procedures? No, I don't think so. No. You can check to see if your surgeon is board certified. Mm-hmm. Like in any state, you can look to see, check. Every state has a registry of boarded or not boarded and things like that. But you don't know
but you can't know their numbers. Mm-hmm. No, I think if you call the office or you just meet, I think the consultation is critical.
Yeah.
Somebody could look amazing on social media. You could vibe with them, think they are so funny, but at the end or great or whatever it may be. And but then you show up to the office and they're this weirdo. They can't make eye contact. They don't answer questions. They tell you how they think you should look. You got to feel out all these things. And the consultation is super important. So maybe this person has only done 100 breast implants procedures, but their before and afters align with what your goals are and you like them. Okay, great. Then that speaks volumes versus somebody who's done 10,000, but is an asshole.
Yeah.
Who's going to actually take care of you at the end of the day.
True.
And I say that mostly because I'm young. So I haven't done 10,000, of course, but
only 5.
We'll get there. Yeah, we'll get there.
So let's talk about that elephant in the room. I have had maybe last year, maybe just 2 patients discuss possibly thinking they had what's termed breast implant illness, or I think I've seen it also.
Yeah, there's a new term for it too. I'm going to
BIA or something. Is that what that is?
No, hold on. I have it it's like Asia. Okay. So autoimmune / autoinflammatory syndrome induced by adjuvants. So induced by some type of implanted device. So it's not isolated to breast implants, but that Asia term is for that.
Okay.
But BII or breast implant illness is the other more common, more trending term that if you go to look it on social media or Google, that's what you'll find it. under.
So what exactly is breast implant illness, and what are the symptoms that maybe patients are complaining of that they're labeling it that?
Good question. And good question, because we don't really know. And I know that this is going to get a lot of controversy. I've already spoken about this on another podcast. And, there are warriors who will come out and say that I'm not appropriate to speak on this because I put implants in. But alternatively, I do take implants out regularly, and I take them out for people who have BII or suspect they have BII and people who don't. And I'm sympathetic to that. So let's get that out of the way. But really, BII, or breast implant illness, is a term used to describe a constellation of symptoms, which tend to be, fatigue, brain fog, undescribable pain, myalgia, so muscle pains, arthralgias, joint pains, just depleted energy, maybe some anxiety, maybe some depression. Like, there's a whole laundry list of hair loss. There's a whole laundry list of symptoms that, when put into a pile and associated with a breast implant, some people are basically looping together as a breast implant illness. And, that's not to say it's not real. That's not to say these people are not suffering. But it's just still not 100% sure how this is related, how the breast implant itself is causing these symptoms in these people. Because we do have other chronic autoimmune issues that have similar symptoms in patients with and without breast implants. On the other side, we see people who have these constellation of symptoms take out their implants and feel dramatically better. So it's definitely something that's still being investigated. And I try to stay up to date with the literature to see what we know and what we don't know. And unfortunately, right now, what we don't know outweighs what we know.
Right. So as an internal medicine physician, I speak with my patients in reference to their systemic illnesses and their systemic complaints and things. And as I said before, I had 2 patients last year that felt that they had a breast implant illness. One patient, her implants were in for, I believe, 7 years. And she couldn't exactly pinpoint when she thought she had it, but she felt like she had excluded things that would have caused it. However, I did discuss with her diet, her lifestyle, her alcohol intake, and a few other medications that she was on that could have actually had something to do with her joint pain, her muscle pain. Statins cause muscle pain.
Right.
So I discussed with her, and she eventually did, she agreed that it could or could not be the breast implant. And she did eventually get an explant. And so the reason I wanted to bring it up on the podcast here is that some women, and again, it's likely not all in their head. They're experiencing X, Y, and Z after the breast implant was placed. But when they come to me or when they go to a surgeon and they say, look, I think I've got breast implant illness, I want these things out. They have to go under the knife again. They're having an entire new procedure, whether that's they're having to be I'm assuming when you're going through explant, forgive me, I haven't done plastics in forever. You're tubing these people, right?
Not always. We tend to use twilight sedation. Okay. So in my practice, we don't, but in a lot of practices, yes, it is general anesthesia. Exactly. Which is a hit on your body itself.
Yeah. There's a hit on your body. You have to recover just from that medication of knocking you out.
Right.
You have an entire new procedure to remove what may or may not be causing the problem. So I try to get into it with my patients, again, from an internal medicine standpoint, like what are all of these other things that could be the problem? Because if you remove your implants and you're still not better, what are we doing?
Right.
And you put there's always a risk with that type of surgery.
Yeah.
Well, with anything. But,
absolutely. And it's, obviously people have to weigh the pros and the cons. You need to sit down with your yellow notepad and you need to make your list of things that are good about doing this, things that are bad about doing this, things that may get better, things that may not. And just be real with yourself, real with your doctors, real with your surgeon, because it is a big deal. Once especially if you're someone like myself who started at an A cup or a double A cup, and now you're a C or a D cup, to just take those out, it's not going to look the same. Like you've got to go through a little bit more than just removal. It's not so simple. Not to mention, if you are going to go down the route of, I need an en bloc, capsulectomy. I need to have the entire scar tissue removed. Like, you need to test this. Like, if you are looking for that type of care, you have to understand that there are surgical risks to that. When we start taking out that back wall of the capsule, which some studies have shown that it does not actually increase your symptomatology improvement, regardless if you take the whole capsule or half the capsule. But if you decide that you need that back wall capsule, that is right next to the rib cage. Guess what's by the rib cage? The lungs. Guess what can happen? A pneumothorax. There's a lot of things that can happen. Bleeding, this significant inflammatory response from just doing another surgery. So yeah, it's not a light thing. Infection, it's like, today I think I have BII. Let me just go get an explant. Like, it's not that simple, and it needs to be taken seriously, both from me, both from you, and from the patient.
Yeah.
And you got to think about the reconstruction. Like, what do you want to look like after? You have to wrap your mind around the fact that it's going to look different. Your shape is going to be very much different. Fat transfer is a great option that we have today, but unfortunately, fat transfer is not perfect. Every single fat cell that I transfer into the breast, into the butt, into the hip dips, wherever it may be, does not survive. Right. So you have to know you're going to get one outcome initially, and that's going to change. Yeah. And everybody's different with that. So it's a lot. It's just a lot.
It is a lot.
And I feel for people who have this, or feel that they have this, or feel isolated because they think they have it and no one's listening to them. Like, trust me, I hear you and I feel for you. But you have to really, do your homework.
Right. And insurance does not pay for an explant.
Not that I'm aware of, not in Florida.
So, and correct me if I'm wrong. Well, I don't even know how I would speak on this, but after a mastectomy for cancer, are any of the implants covered by insurance?
Yeah. Reconstruction after mastectomy for cancer, that's covered by insurance. Okay. Yeah.
And, but explants, we're not sure on that.
I don't think so to this date, because again, it's such a,
it's not recognized by the disease classifications as an actual condition.
Exactly. Like, it's just becoming to be a codable diagnosis. Mm-hmm. But I went through, so in preparation for this podcast, I went through the most recent articles. So in the past year, what articles have been published on breast implant illness? There are about 47 different articles just from this year. And yeah, I mean, it's all over the place. What is defined as BII, what is, considered the treatment for BII, what is considered the, etiology, whether it be a biofilm, a autoimmune, ignite, with your IgG or your IgE, whether it be, the actual silicone or particles leaking out into the tissue. Like, literally, you can find one article saying it's a silicone, one article saying it's not. You can find one article saying it's a biofilm, one article saying that it's not.
And then you have to look at who wrote that article.
Of course, follow the money. We always have to do that. But at the end of the day, it's just, I think it's too soon to tell.
Yeah, it's too soon. And I looked as well. And as of, I believe, February 7th, we still didn't have a conclusion on whether or not this is classified as, there's no ICD-10 code as soon as February 7th.
Yeah, it's right. I think it's like something you can write, but not necessarily code for insurance reimbursement, because that's always following behind real life.
Yeah.
I know. I was trying to look up, I have like something here that I wanted to share with you, but you keep talking.
Yeah. So, and then my next question was, do you, and I'm sure there's no statistic on this, but do you appreciate, or do you see a handful of women, or a certain amount of women, that maybe after their explant, they don't get better and then they're wanting a re-implant? Is that something that's feasible if they change their mind?
Yeah, but it's very difficult. So, yes, the answer is yes. I've had, in just, let's say, the last 6 months, I've had several, so more than one, less than 100, come and say, I've had an explant, maybe this got better, but overall not much change in my symptomatology or how I feel. And, I'm just not happy aesthetically with where I am. And I'd like that volume back again. Maybe they're low body fat, so fat transfer isn't an option. There's a lot of things that go into this conversation. But once you kind of take out that capsule, especially if you're taking it out en bloc, so that means the whole capsule around the implant, 360, you're setting up this new shift in the tissue where you're having scar tissue lay down. And if your implants were previously under the muscle, now you've got this layer of scar tissue under the muscle. So to go back in and try to put new implants there, it could very easily be a problem where, I'm in the scar tissue. Now I'm in the rib. Now, I'm going in this territory, and, you just don't want to go down this path of causing more harm than good. Like, we're here for elective reasons.
Right.
At the end of the day, and this is elective. You can have your boobs big or you can have your boobs small.
Right.
It's up to you. It's your life. But to, try to go back in and reimplant, it's definitely something that you have to think about and consider. Like, anyone that I've talked to about this, I've always said, we can go in with the attempt to put it back under the muscle, which is where your initial implant's for. And sometimes we get in there and it opens back up and it's perfect. It's beautiful. We put it back in. I mean, amen. We go about our day. Other times it's not. And maybe it needs to go above the muscle, directly under the breast tissue. And you're setting yourself for a potential higher risk of that capsular contracture, which is such a nuisance. So, really think long and hard about what may be causing the symptoms that you have. If you really narrow it down and in your heart that it's your breast implants, get them out. Of course, do it. Right. Bye, Felicia. You don't need them. But if you are a smoker, if you've got other autoimmune issues that you've had before you got your implants, if you are, drinking 17 sodas a day and chasing it with a bottle of tequila at night, if you don't exercise at all, if you've got high body fat percentage, there's a lot of things that can make you feel bad. And you really got to be true to yourself about what that is.
Right. Right. And again,
sorry, I feel like I'm preaching.
No, you preach, sister, preach. No, well, I mean, and that's the whole reason I wanted to bring it up is because, again, from a non-surgical, from an internal medicine, I'm not going to surgerize you. I'm going to refer my patient to someone like you who I know is knowledgeable, skilled, can deal with having to do an explant. But I counsel my patient, and I hope that the person that I send my patient to, i.e., again, someone like you, is going to tell them hey, look, let's look at this under a microscope before I put you under the knife again.
Right.
Because there's a good chance that your symptoms will remain because there are so many variables that we just don't know.
There are so many variables. And, you will find papers that say, 80% of people get at least one of their symptoms better after explant, but we don't really know if that is 100% because of the explant. A lot of other things could have changed during that surgery, after that surgery, around that surgery that you started to modify based on the fact that you thought you had breast implant illness. And I also just have to say that you should have a little caution when you speak to someone who maybe that's the only thing that they do. And maybe they're also selling you a package of, this holistic supplement regimen. Or maybe, it's this whole buy-in that you need to do. Just be cautious. There are millions of people, who have breast implants, and the rarity of this disease is real. It's very small. Not a lot of people have this problem if they have it. And to make your entire profession around that is just, to me, just be careful. Be careful. If you're doing it, great. But do you also need a holistic supplement package with, 17 sessions of life coaching and, an online membership? I don't know. Maybe you do. Maybe you do. We all could use that.
We need that membership.
But be careful.
Yes, to my listeners, and I haven't counted how many I've seen on the Google search, but if you type in breast implant illness, immediately 1, 2, 4, 5 list of providers, whether they're near to you or 500 miles away, you've got, we are the explant specialists.
The only people who can do it. That's what they say.
Don't trust anyone else to do your explant. They have no idea what they're doing.
Yeah. Yep. Okay.
So be careful with that. Okay. So moving on, I think I've beat that with a stick. The only other comment I will make with the breast implant illness is, and Dr. Kandace, correct me if I'm wrong, I have not noted any specific ANA, any specific white blood cell count, any specific liver markers, skeletal muscle markers. There's nothing that we're seeing that we can define pre-op, pre-explant, post-explant. There's no rhyme or reason on labs, on imaging, nothing that correlates with
directly. Correct. So, and that's so when I reviewed this back in 2022 and re-reviewed it this year in 2024, there's no specific test. There's no test that I can say, hey, we think, I agree with you that you have BII, like you've got something going on and it may be related to the implants. Let's check this marker. There's not one. There just isn't. I hope to one day there will be so that we can answer a lot of questions and a lot of the unknown, but there's not a specific test, like you said, because these levels and these markers that we do have can be elevated from 10 different other things. Mm-hmm. And some of them will stay elevated after you take the implant out. Some of them will actually get higher, so there's really not a good test for that.
Yeah. So from a functional medicine standpoint, make sure you've cleared out everything else except for that implant before.
Yeah. And there are a couple articles that I found interesting. Mm-hmm. So, one of them talked about the correlation with breast implant illness and a vegan diet. And the authors postulated that the vegan diet actually has such a high amount of things like rice that your arsenic levels in your bloodstream are higher, and that could be causing the same symptoms. And then there are other articles that show that not only people that get breast implants, but people that suffer from breast implant illness also have other psychiatric comorbidities. So you're someone with anxiety or you're someone with depression, and then you get this, and then it kind of spirals. So take caution. If you're someone who starts out if you already have autoimmune issues, if you already battle with mental wellness, think clearly before you get your implants, period. But also, make sure that you are addressing those other things before you go through a second or a third surgery to get the implants out.
Is breast implant illness something that is on, I'm assuming it's not, because it's not been defined as an actual diagnosis. So it's not on any consent form or any look for this down the road type of form.
I believe our consent actually does mention that it could potentially be, because we just got new consents.
Good.
Yeah. It is something that's being addressed. Yeah. And I do have patients ask me about it, when I'm consenting them. Absolutely. I'm not trying to hide anything.
Any foreign thing, whether it's temporary or implanted, can cause, a certain type of reaction.
Right. So your knee implant could cause something similar. You could have an inflammatory response around that implant, or you could not. Like most people don't. Yeah. Some people do. It's kind of the same thing with your breast implants. Maybe they are the cause. I don't know.
We need that online membership.
Yeah. We need a life coaching.
Okay. Moving on. So in addition to plastics, what are your most favorite surgeries to perform, and what are your most frequent? Like what are people going to you for? So
we're in Florida, body is everything. We're in a bikini, 11 months out of the year, if not 12. So I see a lot of people for tummy tucks, liposuction, and breast surgery, whether that be implants, explants, lifts, reductions, like anything to do with your breasts, I'm doing it. And the body work, So
you're the body mechanic.
I'm the body girl. I am the body girl.
What about from the neck up?
I do a lot of injectables still. I have partners who are amazing at facelifts and eyes and rhinoplasty. So it's really like, I feel like you should do what you are best at and what you're called to do, not just what you can do. Right. So that's where I focus. I focus on the body. I love doing injectables and I still do those. That's where I started. Yeah. Before I actually transitioned fully into plastics, I had my own med spa, and it was all about the things, the Botox, the fillers, the threads, all that stuff. And so now kind of with my evolution, I'm doing a lot of the body procedures, but still doing the non-invasive stuff for the face.
Yes.
So, yeah.
So as far as the injectables, and you mentioned threads, I particularly like threads in some instances. There are some plastic surgeons, and I'm sure it's because they like to operate, but there are some plastic surgeons that speak against it. What do you think, since you've done threads and everything before, what do you think about threads for certain patients? I guess my specific question is, if I did threads in a certain area on my face today, if I wanted to have a facelift in 1 year or so, did those threads mess with your assessment? Is it going to mess up my surgery later?
Okay. This is a good question and a good topic. And I think kind of like at the root of this, as an aside, is transparency, and knowing that who is providing your medical care, whether that be aesthetic, elective medical care, or real medical care, is transparent with you. Like, this is what I do. This is what I can do. This is what I cannot do. And, having honesty is so important. So keep that in mind when you're searching for a provider. But as far as threads, okay, I was using 2 different types, like the basic PDL threads, with a little bit of barbs on them maybe. And then I was using the Insta Lift that had more of like a cone on them that would really give a little bit more power of a lift. They're interesting. You'll have to look them up. They're pretty cool. And I felt like you could see definitely some changes, like it's obvious when you do it, what you see, those results can settle and they are temporary. But that is the nature of a non-invasive procedure. It's not surgery. I'm not cutting away your extra skin. Right. So I think that they are good. I think there is a role for them. But what can it do down the road? So poor technique, improperly placed, excessive amount of threading can lead to scar tissue under the skin. And that's where we're working if we're doing a facelift. But listen, you probably have patients like me who will never get a facelift. Right. Like my mom will never get a facelift. I will probably get 3. It's fine. We all have balance. But, if someone's never going to get a facelift, then this is not even an issue. Like, don't worry about it. Go about your day, sister. Do what you want. But if you are, and if you're like, I think at age 55, I'm going to be signed up for a facelift. I want to do threads in the meantime. I think just proceed with caution. Know what you're having done. Yeah. Know that the person doing it has done it more than once or twice and that they understand anatomy planes, and you'll be fine. It's not a huge deal. It's not like you can never have one. It's going to mess up the assessment where we can't tell where your skin falls and where your muscle starts.
Like that.
I know, but surgeons are crazy. We are extra, we are wild, and, we are very black and white. Yeah. And that's just really not reality.
Yeah. So to the listeners, if you're wondering what the hell is a thread, so I think many people know what Botox is. Botox is the toxin. They have many different, what do we have?
Botox, Jeuveau, Daxxify, and Xeomin. And then there's one for my stroke patients, MyoBlock, which that's the one I'm saving for. Yes, girl.
For myself. So we have toxins that kind of weaken the muscles that make the shrunk contraction that gives us the wrinkles in our face. So that's Botox. Filler, this is something that is going to expand, give you the volume back. And then we have biostimulators, which I think you still do as well.
Yeah.
So, but threads are something that it's a non-surgical, introduced similar to how fillers are done with a needle. And then when you remove the needle, you're leaving a dissolvable, now they're dissolvable, thread in place to give you a lift that is not permanent.
Right.
Depending on the area and what you need to do, it can add up a little bit. So on my patients, someone young, like us that may want to do a facelift or something later on, I say, look, you're going to pay just as much in threads as you would for a simple, quick nip tuck situation. So I make them go get a surgical consult and get a price and get the info before they decide on either. Because I'm not going to charge you.
Well, that's a transparency role.
Yeah.
Like having a provider like you is great, but there's a lot of people who are not like that and who know, I can't do surgery. I can do threads. Yeah. Threads make me a lot of money. Push. Be wary of people like that.
Right.
I think it's important if you have a cosmetic concern to look at all your options, like from basic, what cream can I use, to what's the most aggressive procedure that I can have, because you're going to fall somewhere along that spectrum, whether it's on the far left or the far right. Like, just know where you are and be realistic with it, and also be realistic with what outcome you want, because that's the other thing. Like, I'm super careful about saying, like, this is what I think you're going to get. No one's going to get the perfect outcome every single time.
Right.
So threads are going to give you that middle of the road outcome. You're going to see a nice change. You're going to have some collagen building, so your skin might even glow afterwards. But is it cutting away extra skin and lifting you? Like, no, it's not.
Yeah.
Yeah.
Okay. And back to a little bit of surgery talk. So you were in bariatrics.
Yes.
For how long?
About 3 to 4 years.
And this was basically the sleeves and the bypasses for weight loss.
Yeah, I was doing the gastric sleeve, the gastric bypass. I was doing some revisions, and I was also doing some lap bands and lap band removals.
Okay.
Remember the lap band?
Yes. I was going to say.
Also a silicone foreign body.
Right. Can you, for the listeners, explain what is the difference between the sleeve, the bypass, and are there lap bands still happening?
They are still happening very, very, very rarely because they're just weird. But
what are those things?
So lap band was like basically a little plastic silicone bracelet that wrapped around the top of your stomach would make you eat less. So it was essentially like, just like putting your hand around your throat and making you not eat. That was a lap band, and you could fill it. So you could tighten it or loosen it by a little port that was on your skin, similar to like a chemo port or a port for like dialysis.
I never did those.
Yeah, those were cool. I mean, to a degree, because they could flip, they could rotate, people would find a way to work around it, eat all liquid calories, things like that. The gastric sleeve is basically removing like 80% of your stomach to where your stomach, which once was a ball, like a balloon, is now the shape of a tube, like a single line, like a hot dog. Okay. So that is both restrictive, similar to a band, but also it has some malabsorptive metabolic components that like we really don't even know exactly how it functions, other than it's decreasing some of your ghrelin, which is your hunger hormone, changing up the way the food transits through the stomach and affecting the mechanism of how the digestion process happens. So that works really well too. Side effect is reflux. So if you've already got reflux, probably not a great option for you. Be careful if your surgeon only does sleeves. Yeah. And then the gastric bypass, which was like Old Faithful, the traditional operation, but more complicated. So it's like cutting your stomach, rerouting it with your intestines so that your stomach is now like the size of a golf ball. And the food then goes directly from that small baby stomach into your small intestine. And so it's rerouting things. It's also affecting that ghrelin hunger hormone, but it's just different. And because you're rerouting things, you're doing more surgery on the inside, there's more potential long-term issues with that procedure. So, those are the main three. There's now some new modifications of all those, the Sadie, the DS, like a lot of things that are like taking it to the next level for people that maybe didn't do so well with one of the initial operations or needs a revision,
How frequently, I'm glad you said that, how frequently do you see repeat customers, or did you see, because, and maybe with your time in bariatrics before you went to plastics, maybe you didn't have so many of them, but it's my experience when I'll have people come in, obviously they're wanting the shot. Yeah. But a lot of them, maybe like 2%, they have either had the sleeve or the bypass twice, or they had it and clearly they've reballooned. Yeah.
So success rates are much higher if you are involved in like a program. So like
the coaching,
kind of like the BII holistic package. It's like if you are also seeing a nutritionist, if you are starting to exercise, if you are making lifestyle changes, because like I kind of alluded to with the band, we can cut out your stomach to where there's 1% left. But if you go drink 17 Chick-fil-A milkshakes, you're going to still gain weight. And so people that struggle with the psychosocial mental aspect of weight gain and weight loss, and there's some trauma in their past and they're not handling that, tend to regain one way or another. Right. And it may not be a year after surgery. It may not be 10 years after surgery. It may be 20 years later. Yeah. You never know. And maybe it never happens. Most of the time it never happens. And once you lose it, you kind of make all those changes and you're thankful and you move about your day and your life, but it can happen. Yeah, definitely. It's hard to know. Like the statistics, they were all over the place whenever I got out of that, but I don't really do it anymore. So I don't want to tell a number.
Well, yeah. And then the thing is too, I probably see it a little bit more than others because people are coming to me specifically for help with their weight loss. And I see patients later on in life when they're perimenopausal, menopausal, and one of their complaints is weight gain. And that's actually due to some hormonal imbalance. So.
Exactly. Right. Weight is multifactorial. We know that. Yeah.
So my other question is, and again, this is just from a wellness standpoint. We have a lot of people walking around that have a lot of things going on and they just want to try to fix one or two and move on to that great upslope. If someone is carrying extra weight, when you were in bariatrics, any of those surgeries covered by insurance? Say if
bariatrics was covered for sure.
Okay.
I mean, depending on your plan, not every plan, but if you were on the like federal Medicare, Medicaid, yeah, covered.
Wow.
But private plans, it depended on, what your employer elected you to have coverage for. Wow. So that would be variable, but yeah, Medicare and Medicaid. And I guess that, depended upon the practitioner, if you take those plans or not.
Yeah.
It was covered.
Oh, that's nice.
Yeah. But you have to qualify, of course. You can't just get it if you weigh 10 pounds too much.
Right.
It's typically a BMI of 40 or a BMI of 35 with medical comorbidities like high blood pressure, high cholesterol, diabetes, sleep apnea, things like
Arthritis?
that.
No.
You'd have to have more than just that.
Yeah.
Yeah.
Okay.
Yeah. But also it's dependent upon the plan.
Yeah.
Some were more strict than others.
I did not know that it was cut. That is great to know.
Yeah. Yeah. Yeah.
All right. And then, I do IV infusions for many reasons. Some brain health, some just anti-aging, some specific vitamin replacement. I have encountered quite a few patients after they've had a sleeve or a bypass that maybe it's due to them eating less overall. Maybe it's due to just their surface area being decreased. Maybe it's due, obviously, to the type of food that they're trying to just take in. But a lot of them would come to me after having a gastric surgery with hair loss, dry skin, just, feeling emaciated, low blood pressure, just because they're not able to take in those things. How do you feel about the vitamin replacement option? Did they do that at your office?
So again, that is all so related to whether or not you're in a good program. I was in a bariatric center of excellence. So we did all those things. We tested the vitamin levels before, we tested them after, we made sure they were getting their vitamins, PO afterwards. But if not, then we would send them for IV. So if you're at a good place, most likely your doctor's checking all this stuff and staying on top of it, but maybe you went and got it in Tijuana. Okay. Whatever. We're not mad at you. It's fine. It's cheap as shit. But because if your insurance doesn't cover it, a lot of people do that, and that's okay. But yeah, if no one's watching you, no one's taking care of you, no one is helping you to navigate this post-bariatric life, then yeah, I think vitamin infusions are amazing. I think that's a great way to get some replacement quickly, because there are some critical vitamins that if you don't have them, you get a permanent nerve damage issue that is irreversible. So B1, thiamine, and then I think B12 is also super important for people, mostly the B vitamins.
So that's good. I didn't realize, I would be hopeful that someone is going to follow the trend of those things.
They're supposed to, but also some people just don't go to their follow-ups.
Yes.
So there's also that.
I want to bring it back to plastics. After someone, whether it be via surgery or an extreme weight loss lifestyle coaching online program, coaching program, weight loss program, after they lose maybe an excessive amount of weight, if they have issues with excess skin, maybe legs, abdomen, there are people that have weighed, a lot, and they've maybe lost it so rapidly that they're having excess skin. Are some of those types of plastic surgeries covered after a weight loss?
My primary answer is no.
Okay.
But I think you may be able in certain areas with certain doctors be able to find some of it to get covered.
If you have a medical, maybe recurrent infection or...
Yeah, but it's really difficult, I think. I think it's more appropriate to, find out what's bothering you and get it done the right way with the right person that you trust, then go into a search for the insurance provider, because that can be hard sometimes. A lot of times the plastic surgeons who are still taking insurance, they're doing a lot of cancer reconstruction. They're great at that. But skin removal, aesthetic, that type of surgery is a little bit different. And, if you want to go to somebody who that's what they do day in and day out, there are a lot of plastic surgeons that do just weight loss removal, skin removal procedures.
Yeah.
I do a lot, but there's a lot of places that's all that they do.
Do you see a lot of facelifts after dramatic weight loss, or is it usually just...
So if once you lose, let's say
women
50, 60, 70, and then up pounds, you're going to start looking at facelift, depending on how old you are, breast lift, maybe with implants, because usually they're very deflated, your breast, arms, a brachioplasty, tummy abdominoplasty, which there's different ways. You could either some people are candidates for just a straight tummy tuck. Some people need an extended where we go a little bit further around the sides. Some people, a lower body lift or a belt lipectomy where it's like a 360 skin removal situation. And then a thigh lift. And then, labiaplasty can happen to anybody, but
do you, do the thigh lifts and everything, or are you more torso?
I do all of that.
Ooh.
Yeah.
Ew.
It's a lot. It's a lot of fun. Skin removal. Yeah. It's so rewarding.
Yeah.
Makes a huge difference.
Imagine.
Well, there's a whole psychiatric component to weight loss, whether you did it through surgery, like bariatric surgery, or you did it on your own, that most people tend to still see themselves as large.
Yeah.
And if you're able to kind of go that next step and see yourself in the new body that you reward yourself with, then I think it just kind of puts you in a whole new mindset and a new life. So if you're able to do it, because it is expensive, it's not cheap, like it's not free.
Yeah.
Then it really, I see those people really happy. And it's also a little motivating to never regain that weight, because it's like, oh no, I lost it. I've changed my life. I've gotten so much healthier. And now I've rewarded myself with this expensive surgery. Like I'm not going to go back. Right. Not going to happen.
Yeah.
So
it helps that relationship with food.
Yeah. And it also helps with mobility. That's a big thing. Like a lot of extra skin can limit your activity, can limit your self-confidence, things like that. So there are definitely functional, physical, realistic reasons to have the surgeries after massive weight loss. Yeah. But it's typically not covered.
Yeah.
Yeah.
Wow. I think that would be on my bucket list if I lost all that weight. I would.
No,
have to
I know.
go for
It's
it.
like every time I see somebody that's lost weight, I'm like, congratulations. Like that is huge. Like just you and I to lose like 5 pounds. It's hard work.
Yeah.
Imagine losing 50, 80, 100, like it's a lot.
Yeah. Well, we are thankful for
Kudos to them.
So are there any, topics or procedures that I did not ask you about that you want to enlighten any of the listeners on?
I think I always get asked about BBL and that
the butt.
Yeah. Let's talk quickly. We'll talk about how much time. Oh, we're at an hour. Dang.
Okay.
So we can quickly just talk about trends, like trending right now are small boobs. So explant is happening for people who have BII and don't have BII because they just want smaller breasts. Like it is in vogue. And then the BBL is out. So in small boobs, out BBL. I've actually suctioned away, liposuctioned somebody's fat transfer to their butt because they didn't want their butt anymore.
Wow.
It was great. It was so fun.
I'm coming over.
Yeah. So those are the trends, young girls, the trend, rhinoplasty is still huge with young girls who need that or want that. But then in like our age group, like the 30s, 40s, 50s, it's definitely downsizing the breast, cleaning up the tummy if you've had kids, and just kind of like sculpting skinnier, slimmer bodies with Ozempic, but also with liposuction.
Yeah.
Yeah, that's trending.
Okay. Wow.
Trending with Candy.
Right. There. Oh my God. That's awesome. That's a new podcast.
Yeah.
Well, thank you so much for all of this information. I am enlightened with the explants for smallness and the fact that the BBL's out. You just really hurt my soul a little bit.
I know. Well, you see like Kim and Chloe, like they're getting skinnier. I think they're on Ozempic or something. Who knows?
Oh yeah, they are.
Who knows? That's cutting down on their butts. They still have them though, but I have a feeling at some point they're probably going to get them liposuctioned.
Oh, wow.
Yeah.
Yeah.
Just because they're really out there.
You heard it here first. Mm-hmm. Okay, Dr. Kandace, tell us, where can people find you?
So my number one platform is Instagram at Slimming Surgeon. So slimming, like getting you skinny, SLIMMING surgeon. I can also be emailed directly at that, slimmingsurgeon@gmail.com. And I'm at Haas Plastic Surgery, HASS, in Wellington and Palm Beach Gardens. And yeah, send me a DM. I love to talk to people, but don't attack me because I'm just here with the facts.
Right? Okay. All right, everyone. If you've enjoyed this episode, please give me the 5 stars that I deserve and
Yes.
Dr. Candy deserves. And share this so that people can so that your friends can listen on whichever platform you like, Spotify or iTunes or wherever you get your podcast. And thank you for listening. And again, thank you, Dr. Kandace.
Thank you so much for having me, Bonnie. Yay.
Yay.